from Academy Team GSM. I will be moderating today's case presentation. We have Dr. Parth Gada here today. Let me give a brief introduction about him. Dr. Gada has done his MBBS from GSMC and KEM Hospital and MS General Surgery from GMC JJH Hospital. Currently, he is working as a general surgeon at VN Desai Municipal General Hospital, Mumbai. He has over 10 publications in national and international journals. He enjoys teaching, whether it's teaching maths at an orphanage as a volunteer or teaching basic research methodology or during surgical clinics. I would like to ask Dr. Parth to say a few words before we begin today's case presentation.
Good morning, everyone. Nice to see 15-20 people have come again this morning. Today we'll try to keep it, we'll not try to extend it as much as we did it last time. We'll try to finish it between 1.5 to 2 hours. We can begin.
Good morning, sir. I am Jenny and I'll be presenting the case for today. I'll start with my case now. My patient was a 40-year-old female named XYZ, resident of Kopargaon, homemaker by occupation, Hindu by religion, and she came to the OPD with chief complaints of lump in right breast since 15 days and discharge in pain in right breast since 15 days. My patient was apparently all right 15 days ago when she noticed a lump in the right breast, which was sudden in onset, rapidly progressive, and associated with low-grade intermittent fever. Pain over right breast was localized, sudden in onset, and throbbing in nature, non-radiating, non-cyclical, associated with greenish-yellow purulent discharge from the right nipple, was present with no aggravating or relieving factors. There is no history of inversion of nipple, discoloration of breast, ulceration over breast, trauma over breast, cough, chest pain, hemoptysis, loss of appetite, yellowish discoloration of skin, headache, vomiting, weakness, and low back pain. Patient complained of a similar illness in the past 4 months ago, for which she visited a local doctor and was given oral antibiotics and was apparently relieved of her symptoms. No history of previous surgeries. No history of diabetes, hypertension, tuberculosis, chronic obstructive pulmonary disease, or bronchial asthma or epilepsy. There is no history of any addictions, no known drug allergies. There was no significant family history present. Menstrual history. Menarche was at 14 years of age. Age at first child was 18. All 4 births were normal vaginal deliveries. Total 4 children. Oldest is 22, youngest is 7. Married since 23 years. Breastfeeding till 1 year of age for all 4 children. There were regular cycles, moderate flow with no history of dysmenorrhea. The differential diagnosis based on history was bacterial breast abscess, antibioma, infective granulomatous inflammation, invasive breast carcinoma, inflammatory breast carcinoma, fat necrosis, discus disease, xanthogranulomatous mastitis, and pagetoid spread of lobular neoplasia.
Okay. Very good. Yeah. Let's start again. Let's start over.
Okay.
Great presentation. Let's come to the first one. Okay. Let's begin. From the age, what comes to your mind when you are talking about breast lump in the breast with respect to age?
So she's a 40-year-old female. So according to the ANDI classification of disease, she's in the later reproductive age group or in the involution age. She's in somewhere in the middle. So in the later reproductive age group, it may be cystitis, or in the involution group, it may be duct dilatation or sclerosis of the duct, or there may be atypical hyperplasia of the duct systems. Then there, as she's an older age and there is non-cyclical involvement, so fibroadenoma may be excluded out of the.
Very good. Most common age group for fibroadenoma is?
Sir, early age group, so 20 to 25 years of age, early reproductive age group.
Okay. How do you can you tell me about ANDI in brief?
Sir, ANDI is aberration of normal development and involution of the breast. It is divided into 3 parts: early reproductive, late reproductive, and disease of involution. So in early, we can have giant fibroadenomas.
In that, we can divide it into 3 columns: normal, disorders, and diseases.
Yes.
So we have a table of 9 by 9, 3 rows and 3 columns.
Yes, sir.
In early,
first normal was lobular development. So, which is fibroadenoma. The disorder is giant fibroadenoma.
Hmm.
Then nipple inversion. Nipple inversion. Uh, Mammary duct fistula may be present. And then for later reproductive cyclical changes, so that is associated with mastalgia. And then uh, hyper proliferation of the duct system during pregnancy.
Yeah.
So that
And the
is
last part you already said about the cyst and involucral. Okay. All right. Proceed. And what about the sex? What is the importance of sex in this?
so a female, so she has a
Hmm.
higher chances of breast
How much?
carcinoma.
How much is the incidence as compared to a male?
So 32% of females develop life. Sorry,
Yeah,
sir, I
that
don't.
is out of all the breast cancers in one female. But I'm
Uh,
talking about female with compared to a male. What are the chances of developing breast cancer? You can straight away say don't know, so I can give you the answer and we can move on.
don't know, sir. Sorry.
Yeah. The incidence is 200 times.
200.
Females are 200 times more likely to get breast cancer as compared to a male.
Okay, sir.
What is the annual lifetime risk of breast cancer in an average female? Lifetime risk of breast cancer.
Don't know, sir.
It is 12%. So, if 1 in every 8, 12 to 15%. So, 1 in every 8 people will have breast cancer once, at least once in their lifetime. And the 7 out of 8 people will never get a breast cancer.
Oh, okay, sir.
Proceed. Chief complaints are read.
Lump in right breast in 15 days, discharge and pain in right breast in 15 days.
Lump and discharge and pain.
Hmm.
So the lump that she is complaining of, is it a chronic onset or an insidious onset? Is it a acute onset or a chronic onset?
Acute onset, sir.
Acute onset. So what are the differentials you have in mind when you have an acute onset of lump? First differential.
Breast abscess, so, acute bacterial breast abscess, or a very aggressive type of carcinoma, inflammatory carcinoma, lactoceles, but she's not mass. She's
Correct.
not.
There's no history of that. And discharge and pain. So yeah, proceed. Next slide. Which are the points that are helping towards the case of breast abscess? Which
Sir,
important
it was
words in your
sudden,
history? Yeah, sudden one. Then
rapidly progressive, and associated with low-grade intermittent fever.
all three are important, and all three together will straight away tell you the diagnosis that you are talking about breast abscess. What
Breast
other important points about the pain?
The pain is throbbing in nature, but
Yeah,
normally in
that is
carcinoma, the pain is dull aching in nature.
correct. Non radiating and non cyclical. So, do you know about the cyclical nature of pain with respect to breast?
So, as in Andy, in the late reproductive, that mastalgia, cyclical proliferation leads to mastalgia. So, that is, we can rule that out because of the non-cyclical nature of the pain.
How will you treat cyclical mastalgia?
Sir, NSAIDs and fermentation.
What else? Like primrose oil and NSAID. Okay, what else? What does primrose oil contain? Question is open to audience also. I'm looking at the chat box. Galloninic acid, gamma linolenic acid. So what does that do? How does it help in the treatment of fibroadenomas or fibroadenosis and cyclical mastalgia?
Don't know, sir.
Anyone in the audience? Yeah. Changes fatty acids to from saturated to unsaturated fatty acid. What is the dosage and how long will you have to treat with primrose oil. To 25 milligram BD. Okay. The treatment is 300 to 500 milligrams per day for 3 to 4 months. What else? What other tablet? You must have seen in the OPD that's generally prescribed for cyclical mastalgias and fibroadenomas, along with unique primrose. Tamoxifen, not very early. Some vitamin that we give.
That's a vitamin.
Vitamin E, correct. So vitamin E capsules are given along with NSAIDs and along with evening primrose. All right. What other advice can you give to the patient that causes cyclical mastalgia or mastalgia? With respect to the clothing, with respect to our undergarments.
Better underwear garments, so better breast support with
better as in what? Better as in what?
No clue, sir.
Good support, yeah. So ideally, sports bras can be prescribed such that it is giving complete support to the breast, which can be just about the right size or just smaller than the size of her breast. That type of sports bras you should prescribe to these patients. Because usually you will see such patients in the OPD, they don't wear good undergarment support. Okay. So your patient has pain which started 15 days ago, a lump which she noticed 15 days ago, sudden onset, rapidly progressing with fever. Pain was also localized, sudden onset, throbbing in nature, non-radiating, non-cyclical, with discharge. All right. So can you tell me about the nipple discharges types and what do they signify?
Sir, serous discharge may be present, or bloody discharge may be present, or purulent discharge may be present. So serous discharge may be present in cases of carcinoma, inflammatory carcinomas. Bloody discharge may be present in inflammatory carcinoma.
Serious and inflammatory carcinoma?
No.
Okay, go ahead. What else? Let's complete, then I'll correct.
Bloody discharge in DCIS, ductal carcinoma in situ, or lobular carcinoma in situ, or any atypical ductal hyperplasia may present with bloody discharge. Purulent discharge may be present in cases of lactocele or mastitis or breast abscess.
Okay. Is that it? Are you done? Anything else?
Yes, sir.
Okay. So when you are asked about nipple discharge, first you should begin about physiological and pathological. In physiological, what will come?
Milk.
Okay. During lactation.
Lactation.
Lactational milk discharge during lactation. That is physiological. And another rare thing which is slightly digressing from the topic, but even neonates can secrete milk from the nipples. No, I'm not going towards galactose, but even neonates secrete milk from the nipples. Have you heard of it? Is it normal? Is it abnormal? Yeah.
It's normal.
Correct.
But it's rare.
Yeah. It happens because of the maternal hormones that in the initial days of birth, after birth, neonate can secrete milky discharge. So physiological discharge. Now we come to the pathological discharge. On the pathological side, discharge from the surface of the skin and discharge from the nipples. So discharge from the nipple surface, what will come in that? Audience? Abscesses and all are inside. What is on the surface? Skin conditions that cause discharge. No.
Sebaceous.
Eczema. Eczema of the nipple can cause nipple discharge from the surface. Then we come to the nipple discharge from the ducts, through the ducts. Under that, we can classify it as discharge from a single duct and discharge from multiple ducts. Okay. So when you come to discharge from the single duct, and when I say it is bloody, then what will come to your mind? Bloody discharge from a single duct. First thing that comes is
Ductal carcinoma in situ.
intraductal papilloma. Very good.
Ductal.
Seal has answered. Intraductal papilloma. Then serious discharge from a single duct. Ectasia, okay. Now we come to multiple ducts. Discharge from multiple ducts. Under that, if I say bloody discharge from multiple ducts, then what is the most common thing? You have already said it. I'm just revising it and presenting it in a presentable way so that you can answer it in the exam. TCIS and carcinomas. Greenish discharge from multiple ducts.
Bacterial infections, cysts,
Duct
pseudomonas.
ectasias. Duct ectasia is very important when it comes to greenish discharge from multiple ducts. And finally, purulent discharge from the multiple ducts is breast abscess. Okay. Yeah. So till now, we have our set of differentials. Can you proceed?
Yes.
Okay. Please read. Can you tell me the rationale behind asking all these questions?
Sir, with inversion of nipple, we can rule out any involvement of the skin or it is attached to the chest wall or not. Discoloration of breast, we can rule out if the lymphatics have been involved or any blood supply to the breast has been compromised. Ulceration of breast, we can see if the carcinoma has locally advanced to the skin or not. With trauma over breast, we ask this to usually rule out fat necrosis, which is again a benign condition of the breast. With cough, chest pain, and hemoptysis, we are ruling out metastasis to the lungs. Loss of appetite, yellowish discoloration of skin, headache, vomiting, we are ruling out mets to the liver or the brain or the central nervous system. And low back pain, again, we are ruling out mets to the bony parts of the body.
Okay. So you could have better presented this as negative history. In the first part, you should rule out negative history for etiology. So you can't put trauma over the top because first you have to rule out other conditions, right? If you have breast abscess as a differential in mind, and you have to rule out other conditions like breast cancer, traumatic fat necrosis, galactoseals, or antibiomas, or any other cysts that come to your mind. So history regarding all that will come at the top. So no history of recent trauma to the breast, which has given rise to a breast lump. That will come at the top. Then if you want to rule out malignancy, so you can say no history of inversion of nipple. What is the significance with related to inversion of nipple, whether it's recent or whether it's already inverted? Are you getting my question?
Yes, sir.
Is yeah, people from the audience are answering it. What is important when you talking about nipple inversion? It has to be of recent onset.
Okay.
So in your negative history, you are first ruling out history of etiology. So you can say trauma to the breast separately as the first point. Then if you want to rule out malignancy, then you can rule out directly by asking about no history of any lump in the painless lump, hard mass in the breast with features of nipple inversion, ulceration, etc. All that should come in one line. So that means that you are talking about a breast lump. When you are talking about individual things, it does not mean anything. Okay. And then when you're talking about all the features of metastasis, you can also take them all as one line. Although it is of more benefit when you have your first differential as a malignancy. But it's good that you have written all that because inflammatory breast cancer is still one of our differences.
Mm.
So all these history of metastasis, or you can if you have this as a short case, You can also say no history of features suggestive of metastatic breast disease in one line. And then when the examiner asks what are the features, then you can enumerate all of them. If you have short of time. Okay, proceed. Inflammatory breast cancer you can keep as a because there's a question from the audience. Inflammatory breast cancer, you will get a history from your you will get a history which is rapidly progressing, and based on examination, which will be totally erythematous, redness, more than one third of the breast will be involved. In that case, you can keep it as a differential in the clinical diagnosis. Obviously, the diagnosis has to be histopathological and imaging after imaging also. Okay, personal history.
There is no history of any addictions, no known drug allergies, and family history, no significant family history was present.
What kind of what kind of family history would you like to ask in the case of breast lump?
Sir, any maternal family history of breast cancer or breast lump, if there is present,
What else?
in sisters or in mothers or in aunts, if it is present or not. Even history of colonic cancer, pancreatic cancer, maybe because the BRCA1 gene mutations or BRCA2 gene mutations. Even in fathers, we can ask because of the BRCA2 gene mutations.
So, colon, pancreatic, what else?
Rectal and ovarian cancer also.
Ovarian and prostate. Everyone is helping you there in the chat. Okay. So, how will you, can you modify your statement in the family history? Instead of just saying no significant family history, you can tell the examiner that you know what is BRCA gene mutations are, all right? So, why don't you tell the examiner in a beautiful one line?
No history of familial, colonic, rectal, pancreatic, ovarian, prostate carcinoma present, and no history of breast carcinoma in the maternal relatives present.
Okay. What is sporadic breast cancer versus familial breast cancer, or sporadic versus hereditary is a better question.
Sporadic is like there will be no family history present, whereas in hereditary a family history will be present. Like on genetic testing, BRCA1 and BRCA2 mutations will be present in the family gene lines.
What else? What is the incidence wise? What is more common that you usually see, sporadic or hereditary?
Sporadic is more common.
Around 70 to 80% of the cases are sporadic cases. 10 to 20% of all the breast cancers that we see are hereditary breast cancer cases. Okay. Male breast cancer is associated with which one? BRCA1 or 2?
BRCA1.
No, male is with BRCA2. Personal history, no history of any addictions or drug allergies. Okay, proceed. With respect to drug, can you come back? Yeah. Apart from drug allergies, if you want to ask about medication history with respect to breast lump, which drugs will you keep in mind?
Oral contraceptive pills.
Okay. Hormone replacement therapy, people are answering. Yes. That is called for breast cancer.
In
What
males,
are the breast lumps? Yeah.
aldosterone antagonist is present, like for gynecomastia, so aspironolactone.
What else?
Anti-tubercular therapies.
Not exactly. Okay. There is a whole list of drugs causing gynecomastia. Can you name 3, 4 of them? You have answered one, spironolactone. What else? Digoxin.
Aldosterone antagonist.
Yeah, that is spironolactone. Ketoconazole, that's correct.
H1 antagonist.
Cimetidine, yeah.
Metadine. 5 alpha वो क्या था 5 alpha वाला?
Estrogens. Okay, that's it. So 4 drugs are there. These are one of the common drugs that people say, isoniazid and corticosteroids.
Got it.
So what is the mnemonic for this? The mnemonic is DISCO.
Oh,
Digoxil, isoniazid, S
uh,
is steroids, C is cimetidine, O is estrogen. Okay, drugs that cause the gynecomastia. Okay, proceed.
Menstrual history. Menarche was at 14 years of age. Age at first child was 18. All 4 births were normal vaginal deliveries. Total 4 children. Oldest is 22, youngest is 7. Married since 23 years. Breastfeeding till 1 year of age for all 4 children. Regular cycles, moderate flow, and no history of dysmenorrhea.
Okay. What is the significance with respect to breast cancer?
Uh,
What are the high risk factors for breast cancer in this?
High risk factors for breast cancer is more estrogen exposure. So that occurs when there is early menarche and late menopause, or the cycles are delayed and not regular in nature, or there is a late first pregnancy. So in our case, menarche was at 14 years of age, which is the normal age of menarche. It is not early menarche. Then age at first child is 18 years of age, which is not a late pregnancy. And all no breastfeeding is also a risk factor for breast cancer. So breastfeeding till 1 year of age was present for all 4 children.
Okay. First, we'll talk about breastfeeding. How much of this is a very important question. How much of breastfeeding is protective against breast cancer? How many months? Minimum of how many months is protective?
No, I don't know.
Suppose people are answering 1 year. Minimum is 6 months and ideal is 1 year. That is protective for breast cancer. If a female has breastfed only for 2 or 3 months, and suppose something happens and she cannot breastfeed any further, then that is not considered as a protective thing for breast cancer. Okay, so minimum period of continuous 6 months of breastfeeding is needed to be included as a protective factor against breast cancer, and ideally is 1 year. What is the cumulative? Now you have said breastfeeding till 1 year of age for all 4 children. So she has totally breastfed for 4 years of her life, correct?
Yes.
Is that significant? Is that all 4 years of that will be contributing to the protective factors? How much is the maximum age limit for that? When you talk about breastfeeding as protective factor, how much is the maximum upper limit? The answer is 2 years. 6 months is the minimum, 1 year is ideal, and maximum 2 years is protective for breastfeeding. Okay. Now we talk about menarche. Is age at menarche at 14 years significant? More than 14? That's normal, right?
Yes.
So what if uh, what do you know about any uh, risk assessment models for determining the age of determining the incidence of breast cancer in later life?
I think it's the Gale model or
Yeah,
something.
correct. Very good. I'm surprised you know that. So, Gale risk assessment model will tell you, depending on the various factors that you put in, age at menarche, age at first child, history of previous biopsies, previous surgeries, incidence of breast cancer in first degree relatives and all, and it will tell you the relative risk of breast cancer in that female. So, if the age at menarche is 12 years, the relative risk increases by 1.2 times. If the patient has first child after 30 years of age, the relative risk increases by 5 to 6 times. So you will get all the details. Obviously, you don't have to learn all these. All these details are available, and you just have to know about such. Okay. So I get menstrual history of all this. This will come as menstrual and obstetric history, right? Because you're talking about the deliveries. Then regular cycles, moderate flow, no history of dysmenorrhea. Okay. What else can you add over here? No history of intake of hormonal replacement therapy and What other history can you add over here? No history of abortions. Proceed. Okay, differentials. What is antibioma?
Antibioma forms because of the treatment with antibiotics is not completed and antibiotic resistance is there. So the bacteria basically form the biofilm around it. So it forms like a lump in the breast.
Okay. Infective granulomatous inflammation. Okay. Can we proceed? Yeah, begin. We'll complete the whole examination now, and then we'll come back to general examination.
My patient was conscious, cooperative, well-oriented, time, place, and person. Height was 160 centimeter, weight was 48 kilos, BMI was 18.7 kgs per meter square. Pallor was present, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema were absent. Head to toe examination was normal. Vitals, pulse was 90 beats per minute, regular in rhythm, volume and character were normal, no radioradial delay or radiofemoral delay was present. Blood pressure was 122 by 82 mm of Hg, taken in the right arm in the supine position. Temperature was 99.9 degree Fahrenheit. On local examination, inspection, left breast was normal. Right breast was slightly red, enlarged and lower than the left breast. Visible swelling in the right breast in the upper outer quadrant, approximately 5 into 4 centimeter. There was no ulcer, nipple abnormalities, cracks, fissure, no pseudo-orange, fixity to chest wall, retraction of nipple. Swelling does not become prominent on contraction of pectoralis. Areola of both breasts were normal. There was no difference in size. No cracks, fissure, ulcer, is eczema, discharge was present. No nodules or edema over arms was present. Palpation, inspectory findings were confirmed. There was local rise of temperature, tenderness was present. There was a single swelling present in the upper outer quadrant of size 4 into 3 centimeter, globular, irregular margins, firm in consistency, not fixed to the skin, no intrinsic mobility, no fixity to muscles, no fixity to chest wall. Left breast was normal. On palpation of axillary lymph nodes, not palpable.
Okay. Diagnosis.
Findings were normal. My patient is probably suffering from breast abscess of the right breast.
First slide, general examination. Okay. What is the significant thing over here that you found? Two significant things.
Sir, the patient was normal in weight, and obesity is a risk factor associated with breast carcinoma. And pallor was present, basically, which means the patient was undernourished or malnourished.
And what about BMI?
BMI was normal. 18 to 25 is the normal BMI for Indians. So she's 18.7 kg per meter square.
Is it on the higher side? Is it on the lower side?
Yes, sir. It is on the lower side.
18 to 25 is normal. What is underweight as per BMI classification?
Less than 18.
Okay, pallor is present. At what HB level will you see pallor present in the conjunctiva? If the pallor is present, around 9 to 10.
9.
And you will see a loss of these creases at what HB level? Less than
5.
5 to 7. So pallor was present. So the HB is not more than 10 for sure. Okay. Icterus, cyanosis, clubbing, were absent. What about the other things that you should add at the start of the examination? How did you examine? Did you take consent? Who was present? Where did you examine? Can you tell me about that? Can you add one more line? Patient was examined.
The patient was examined after taking her consent, and the procedure was well explained to the patient. The patient was examined in a well-lit room with the patient in a comfortable position, which is
what position?
in the supine position for now. We'll make or sitting position in whichever she's comfortable. And
No, not in whichever she is comfortable. You have to tell the position because your examination will depend on what is the position, and based on that, you will have to tell the position to the patient. So you have to tell the position to the patient.
sitting position. We'll examine her in the sitting position in the start, in a well lit room, and we'll ask her to expose herself from the chin to the umbilicus.
Okay. Can you again tell me in a more refined way, or you will repeat after me? Patient was examined in a well-lit, well-ventilated room with due consent, with adequate exposure above the waistline, in the presence of a female chaperone. What did I miss? In the sitting position. Can you repeat that?
Patient was examined in a well lit, well ventilated room, with her due consent, and in a
Presence of
in the presence of a
female chaperone
in the presence of a female chaperone, and was
in the sitting
in
with
the
exposure
in the sitting
above
position
the waistline in the sitting position.
with exposure above waistline in the sitting position.
Okay. So people in the chat box are asking about various types of positions and how should you examine a case of breast abscess. So now if I think it's a case of breast abscess, I need not examine in all the positions. But as far as the case of breast lump for malignancy goes, you have to examine the patient in all the various positions. Suppose this is a case of breast cancer, how will you in what all positions will you examine the patient? And on what will the significance of each position?
Sir, I will start with the sitting position and look at the nipples of the both the breasts and see if any nipple is below or above, in relative to each other.
Nipple displacement.
Nipple displacement. Sir. Then I'll ask the patient to lean forward.
And you will look for nipple deviation. Okay, and it will tell you about any fullness. How will you see for nipple deviation? It will be with respect to the
mid-clavicular
midline. Nipple deviation is from the midline. And what about nipple displacement? It will be with respect to
mid-clavicular
mid-clavicular point. From one particular point, you'll have to see whether it has gone up or whether it has gone down. Okay. Then we come to so that is the sitting position. Which is the next position?
Leaning forward.
Okay, that will tell you about forward. That will tell you about fixity to
chest wall.
Very good. Third position. Which is the third position?
Hands over the waist. Hands over the waist. Okay. Relax without contraction of the pectoralis.
Okay. Pectoralis. Then what else?
Then hands over the waist but with contraction of the pectoralis.
Okay, that is that same thing. Next.
Then supine position with 45-degree hands over the head.
For?
Any retraction, nipple retraction will become more prominent, and any dimpling over the skin will become more prominent.
Very good. What else? And to look for axilla and to look for lower quadrants of the chest. Fourth. What else? Which other position? Last position is?
Supine position.
Supine or semi-recumbent it is better. Or you can say with a pillow below her scapula on that side. Semi-recumbent it is preferred because it will when the breast mass is large, when you tell the patient to lie semi-recumbent about 30-40 degrees recumbent, you can palpate all the areas of the breast properly. So semi-recumbent can be done especially if the breast is pendulous or mass is high. So these are all the positions for breast assessment. Okay. Can you quickly tell me about fixity to the chest wall, fixity to chest pectoralis, fixity to the skin, fixity to the inside the fixity to the breast mass, all the tests that you do?
Sir, we'll start with skin fixity. So after localizing the lump, we'll try to pinch the skin over the lump. If the skin is pinched and lifted, that means the lump is not fixed.
Okay.
Then we'll start with lump with the breast tissue. So we'll fix the breast tissue with one hand and we'll try to move the lump with the other.
Okay,
If it is
next.
moving,
Next. Yeah, next.
then for pectoralis, we'll ask the patient to put the hands over the waist and be in a relaxed position, and we'll try to move
Very
the
good.
lump in the way of the fibers of the pectoralis muscle. And if it is movable, then it is not fixed to the pectoralis muscle.
If it is
Mobile.
immobile from first, then what does it mean? Even
If
without contraction, it is immobile. Then what does it mean?
If it without
Very
contraction,
good.
it is fixed to the chest wall.
Yes. So that is the first thing that you see. So after keeping it relaxed, if it is still not moving at start only, then it is fixed to the chest wall. Second, now suppose if it's mobile in both the directions, parallel and perpendicular. Now what will you do?
Now we'll ask her to contract and then move. If it
Contract
moves,
में patient को क्या बोलोगे?
Put pressure over the waist,
Hips.
and we'll check whether the anterior axillary fold is taut or not. If it is taut, it means she's on.
Very good. And in what direction will you check?
Sir, along the fibers of the pectoralis and
what is the direction of the pectoralis major muscle?
Upwards and outwards.
Outwards, very good. And then if it's immobile when it's contracted, then what does it mean? But mobile when it was relaxed, then what does it mean? It is fixed to the pectoralis major muscle. Okay. Very good. We can proceed next. Everything is normal. In the temperature, if you don't have the thermometer, you can just say patient is afebrile. You don't have to give the exact temperature. Afebrile, pulse, BP, saturation. If it's available, just mention the saturation. Next. Okay. What are the inspection? We talked about breast nipple deviation. We talked about this. What is poda orange?
So pseudo orange is the
poda orange.
Acha. Poda orange.
Poda orange.
Poda orange.
Yes.
Poda orange is the it basically looks like the skin of an orange. It is usually due to the lymphedema present when the lymphatic vessels are blocked due to either metastasis or enlarged lymph nodes.
Blocked? What lymphatics are blocked? Which lymphatics are blocked?
The axillary lymphatics or the internal mammary, internal thoracic.
No. अगर इधर का block होगा, then this will not become poda orange. If this gets blocked, then you will get lymphedema. If the axillary lymphatics get blocked.
Internal mammary then.
The answer is subdermal lymphatics. Lymphatics just below the skin, which are the superficial lymphatics. So the correct answer is not dermal or superficial. You should say blockage of subdermal lymphatics due to metastasis due to the malignancies will cause blockage of the lymph flow, which will cause edema of the skin. And then why this appearance comes, people have already answered. Hair follicles and sebaceous glands will stand out and will give you a look of the poda orange appearance. Okay. Is poda orange specific for malignancy? Is it sensitive? Is it specific? Can you see poda orange in other conditions apart from malignancy?
Sir, any condition which may block the subdermal lymphatics may cause
poda
orange. It is not specific for breast cancer.
Very good, correct. It can be seen in breast abscesses also. It can be seen in other conditions also. So it is not specific for breast cancer. Okay. Is dimpling, tethering, all these things, is it specific for breast cancer or this is seen in other conditions also?
It may be seen in other conditions also, as like if the Cooper ligaments are involved, it may lead to
even which other condition do you know in which Cooper's ligaments can be involved apart from breast cancer?
No, sir.
No, it is specific. Dimpling means breast cancer. Podorans does not necessarily mean breast cancer. It can be anything else also. So I will not be surprised if you can have podorans in your case also. Okay.
Oh.
How will you check for podorans?
So we press.
Squeeze the skin. You will squeeze the skin and see. So it will aggravate the blockage and you can definitely see it better. Podorans. What is the difference between dimpling, tethering? You got the question?
Yes, sir. I got it.
Tethering is a, dimpling is a sign. Okay. What else? Who else is answered? Difference between dimpling, tethering, puckering.
It's tethering. If we move the breast mass, the tethering will. I don't know, sir.
Let's wait for others to answer if they want to. 'Anyone else? Okay, I'll tell you. Tethering is the process where the infiltration of the Cooper's ligaments is taking place. It is a pathological process. The process is called tethering, where something, when you tether something, it's a word where when you tether something, किसी को बांध देते हैं. That is called tethering. And dimpling, when you see on the skin a dimple appears, that is called dimpling. So dimpling is what is an inspectory finding, and tethering is the pathological process behind it. Okay. So tethering causes dimpling as a process. All right. Areolar. Okay. First you talk about the mass, then the skin, then the nipple, then the areolar. No difference in size. No cracks. Fissure also the eczema. Fissure. Can you tell me the difference between eczema and previous disease of the nipple?
Eczema will be over the areola, whereas the pagetoid disease of the nipple will involve the nipple and the eczema.
Okay, nipple
There
will be destroyed
discharge
in
along.
discharge will be there in both. Okay, what else? Eczema causes itching and it is bilateral, correct? And there is no induration. Whereas in Paget's disease, there will be no itching, there will be induration, it will be unilateral, and nipple destruction will be there. And the underlying disease will be, you will be able to see BCIS or other malignant signs. Okay, no nodules, edema over arms. What do you want to ask for when you ask for edema over arms?
Swelling over arms. So if any bangles have gotten tight or any rings have, any jewelry has become tight or clothing tight.
Why are you asking for edema over arms? What does it mean? Why are you looking for edema of arms?
Any metastatic deposits in axillary lymph nodes, which may lead to lymphedema.
What is the incidence of lymphedema after MRM, modified radical mastectomy?
It is very frequent, but I don't know the exact incidence.
Some say up to 50%, some say about 20%. What is cancer and cuirass?
Sorry, sir?
Cancer and cuirass. ENCANCER, ENCOIRASS.
Don't know, sir.
When you have malignancy all over, cancer deposits are there all over the chest wall. It looks like a armor shield. That is called cancer and cuirass. It's like a late stage of cancer. Proceed. Palpation. Okay. Please read.
Local rise of inspective findings were confirmed on palpation. Local rise of temperature was present. Tenderness was present. Single swelling in the upper
Wait,
outer
wait.
quadrant.
First, you should always say the opposite breast was normal at the first that you have written below. That can come at the first because when you palpate, you have to palpate with the normal side first. Why?
To assess the pathology in the disease side,
No,
like
but why do you
to
check for
know
the
the
normal
if
side first?
to compare and contrast.
Yeah,
Like,
to get the feel of the breast, how dense the breast is, and only then you will be able to compare, right? If you don't know what
yeah.
is normal, you will not be able to compare the abnormal. So the opposite breast is normal. Then there is
Local rise
local
of
rise of
and tenderness
temperature.
present.
Okay. Then
Single swelling present in the upper outer quadrant of size 4 into 3 centimeter. It was globular, with irregular margins, firm in consistency, not fixed to the skin, with no intrinsic mobility, and no fixity to muscles, and no fixity to chest wall.
okay. What is the most common quadrant where breast cancer is involved, and how much is the percentage?
Upper outer quadrant.
How much is the percentage?
Percentage. Don't know, sir.
60 to 70% of the breast cancer is in the upper outer. The rest it is 15, 15, 5, and sorry, and all the other quadrants, and in 5% below the nipple area. Okay. So now basically you have a swelling. So in what things are you describing the swelling? You are talking about the size and the shape. So you told 4 by 3 centimeters, and you told about the globular the shape. How should you ideally measure a case of breast lump with what instrument? For a breast cancer, I'm saying specifically, not for a breast abscess, it's not necessary. Suppose you have a case of breast lump, which is about 3 by 2 centimeters. How will you measure with what instrument and with what method will you measure the size dimension? Will you take a ruler? Ruler has to be a wooden ruler or a plastic ruler which is malleable. What kind of instrument or anything else? Will you take direct meter? Will you take because you have a globe over you, na? So will you take diameter from here to your pura as a room ke circumference wise, or will you take the diameter? How will you give 4 centimeters? Audience,
Diameter.
I'm
We'll
looking
always
for
take
an
the
answer.
diameter.
Yeah, we always take the diameter. Okay. But
Di-
then, how will you check the diameter? That's the question.
Cardboards, but too small cardboards.
Cardboards. Something
Mm.
better can you come up with? Audience. Okay, I'll give you a hint. You have used this in your 11th standard junior college stuff.
Calipers, vernier calipers.
Correct. You should use vernier caliper. Irregular margins, what does it signify?
Uh, that there is invasion into the breast tissue.
Basically, it's not a fibroadenoma or a malignancy, which is which
It's not
have clearly
capsulated.
defined margins.
It's not capsulated.
Yeah. Form and consistency. What what are the various consistencies of a swelling that you can see, which you can feel? Consistency types are very good. Firm, hard, and soft.
Mm.
And which is classically described as what is soft? Soft is
Mhm.
firm. Yeah. Have you heard of this?
Mhm.
Only one person is answering. Where are others?
No stick.
Soft, firm, and hard. Very good.
Hard.
This is soft. This is firm, no step, and this is hard. Got it?
Mm. Yes.
So, if it's breast abscess, do you think it will be cystic or do you think it will be a soft tissue?
Sir, it will be a cystic
Okay.
thing.
And cystic cavities, will it be soft or will it be firm?
It will be soft.
Then why are you getting a firm consistency? or is there a fallacy?
I think there is a fallacy.
Can cystic cavities be firm or can it be hard? Cystic swellings.
Sir, if it's filled with secretion,
That's the thyroid paradox, in which
uh,
firm swellings become hard. Cystic swellings, when they are tense, it feels hard or firm. In such cases, when the swelling, see, how do you feel it is soft or firm or hard? If you take a balloon and if it is filled with air, if you press it, you will feel it soft. If it's filled with air, which is up to totally filled with air such that the balloon is taut and there is no other place for expansion, then that same balloon you will feel it's hard only. Correct. If the balloon is soft and where it's not totally full, up to its maximum capacity, then you will feel it's soft. But when it's filled to the maximum capacity, that same balloon which is filled with air, you will feel it's firm to hard. So basically, it also depends on the volume inside it. That is why you may call it firm. I will give you. I will not call you wrong in that if you are feeling it's firm. It can be soft or firm. All right. But I just wanted to highlight that you are not wrong if you feel that it's firm in that. You don't have to get confused. Okay. What are the various methods of palpation of the breast?
using the palmar side of your
How many fingers?
the three fingers, index, middle, and ring finger.
Okay. Why not uh, with digital palpation that we do? Why not this? Why with the palmar surface of the fingers? This will be more sensitive. No, if anything is there, if you want to feel it, this will be more sensitive to feel. Or is this more sensitive? I can feel this better, no, if I feel it like this. Then why do
Palmar
you want
will
to? Yeah, tips are
cover
more
more.
sensitive, no? If I'm doing it with my
Uh,
tips, it will be more sensitive. This is less sensitive. Then, are you telling me that you should choose a less sensitive method over when you have more sensitive things available?
to increase the surface area of palpation. Like,
That is in the CVS examination when we do first like this, then like this, then like this.
don't know, sir.
Okay, you want a very sensitive method or you don't want a very sensitive?
We want a sensitive method.
You want very sensitive method. But then you will also pick up fibroadenosis. You know what is fibroadenosis?
Yes, sir. It is
What is it?
proliferation of all the ducts of the benign proliferation of all
Yeah.
the ducts in
We
the
studied with Andy, no? It's in that,
heart.
right? Where the breast architecture is all granular and
No.
there are small lumps inside the breast. So do you want to feel that?
No.
No. So do you want a very sensitive method?
No.
No. So we choose purposely to palpate with the palmar surface and not with the fingertips because we don't want a very specific method. We don't want a very sensitive method. We want something which is less sensitive, such that lumps will come in our hands, but the fibroadenosis will not come in our hands. Okay? If you have a breast and if you palpate like this, you will feel some of the other lumps somewhere or the other. Some lumps will always be there, but we don't want that. All those are normal lumps. So only you have to palpate like this with rolling in a rolling fashion, circular fashion with three fingers. Okay, got it?
Yes, sir.
Okay, what are the methods of palpation with the three fingers? In what ways can you do it? Circular, what else? Horizontal, okay. Vertical, what else? Circular is, and one is dial a clock. One is clock method, one is concentric circular, one is horizontal and vertical. In dial a clock, you have to imagine the breast to be a face of a clock, 12, 3, 6, 9, 9, 6. And with each segment, you have to palpate with the 3 fingers. Okay, from 12 o'clock to center, then 1 o'clock to center, then 2 o'clock to center, so on. And in the vertical method, you will go from medial or the lateral border, any one place you select, and then you go up and down like this. Okay, and the horizontal, same way, and the concentric circle method. Okay, that is these are the 4 methods that you can choose. And with every movement, you have to do circular movements, and such that there has to be at least 50% overlap with the previous palpation. Suppose you have palpated over here, now you cannot directly move over here. Your previous palm should have 50% overlap. So from here you can move over here only. Thoda sa. Got it?
Okay, sir.
Okay. Palpation, axillary lymph node not palpable, percussion and auscultation. Okay. Can you tell me about first? No. You don't have to use the tips at all. Just use this palmar surface of the fingers. You never have to use the tips for the palpation. Okay. Can you tell me about palpation of the axillary lymph nodes quickly?
Sir, axillary lymph nodes, we have our 5 groups. So anterior, central, apical, posterior, and lateral. So for the anterior group of lymph nodes, we'll ask the patient to keep the waist on the hand, and we'll support the, if we are palpating the right axillary region, we'll palpate it with the our left hand, and we'll support the patient's right hand on a left forearm, and we'll use the index, middle, and the ring finger, and we'll keep the thumb over the axillary fold, and we'll palpate for the anterior axillary lymph
Very
nodes.
good. Where will our right hand be in that?
We'll be supporting the opposite shoulder of the person for stability. We'll keep it on the opposite shoulder.
Very good. Correct. Similarly, that will be so. What you have described is correct. So your anterior group of lymph nodes you will palpate within the anterior axillary fold, which will be against our thumb itself.
Yes.
What about the central group of lymph nodes, which will be against
the
upper ribs, 2, 3, 4 ribs. Yes. What about the lateral group, which will be against
shaft of humerus?
Okay. Posterior group of lymph nodes will be against
the subscap, the posterior axillary fold.
And apical lymph nodes will be against
the upper first, interior of the.
There is no bony landmark over there. So what you can do is you can place your own opposite fingers on the supraclavicular fossa, and you will have to go very deep inside. That is why it's very difficult to palpate the apical lymph nodes, because you don't have a proper bony landmark. Okay, to feel it against something. Out of all the lymph nodes, which will you palpate from the front, and which lymph nodes will you palpate from behind?
So the anterior, central, and apical will palpate from the anterior side, and the posterior will palpate from the behind.
And lateral from anterior only.
Okay. Anterior only.
Okay, proceed. Proceed. You should always include age of the patient in your diagnosis.
Okay.
45, no? 40-year-old female is a case of breast abscess of right-sided breast abscess. Okay. How will you proceed with this patient?
Sir, we'll order chest X-ray, mammography, total CBC, hemogram, and ECG of the patient. We'll also, since it's a breast abscess, we'll also drain the breast abscess, and we'll send the drain material to culture before starting antibiotics. And we'll start with empirical antibiotics first, and then when we get the culture results, we'll start with the specific antibiotics.
Suppose it's a case of breast lump and not an abscess, and if I ask you how will you proceed after this same step, you are at this same step, and it's a case of breast lump, and I ask you the same question, how will you answer?
Sir, we'll go with the chest X-ray. We'll go for a
triple someone in the chat box itself.
Triple assessment of the breast. So we'll go with the USG, X-ray, MRI, and core biopsy. And
Start with, sir, I would like to proceed with the triple assessment of the breast, which includes clinical examination, imaging, and histopathological examination. First statement will be like this. So the clinical examination I have already done. Imaging will be, what kind of imaging will you proceed with for this first, for breast abscess?
mammography, USG.
Very good. Why ultrasound?
It will be more since there is fluid in the abscess. It will be more specific for the USG will be more specific for the
Yeah.
fluid.
So do you want a mammogram?
So since soft tissue may not be involved in this, mammogram can be done, but it won't be.
It's not needed, right?
It's not needed.
In a clear-cut case of breast abscess, you don't need a mammogram. You will only ask for ultrasound of the breast. Okay. Okay. Then what about what else? How will you proceed? Do you need any confirmation of histopathological examination for breast abscess?
Sir, in this case, since she was presenting with recurrent breast abscess, we can go for the histopathological if there is any underlying pathology present.
What FNSC will you do? What thing?
Uh,
Right now, patient is of breast abscess, no?
hmm,
So what will you get on FNSC? You will get pus cells.
uh,
How is FNSC done?
Sir, using a 22 or a 23 gauge needle and a vacuum aspirator. If
What is a
it
vacuum aspirator? Which instrument is it? How costly is it?
even a needle will matlab,
Needle
injection
attached to a needle
sorry,
attached to a your vacuum aspirator is what?
a syringe, normal
Yeah,
a
very good.
syringe.
So then syringe acts as a suction. You will have to
Uh,
continuously pull the plunger such that a normal suction is available. So right now, if you pull the plunger in air, it will come up, no? But
mm,
once you pierce it under the skin, then you just apply a constant pull over the plunger so that the suction gets generated inside the needle, and then you take the FNEC. Okay. What is the benefits? Suppose it's a case of breast lump. Do you take an FNAC or a biopsy?
Sir, we'll go for a biopsy because with FNSC we will not be able to distinguish whether if it's invasive or not. But with a biopsy we can distinguish whether it's invasive or not.
Any other benefits?
With biopsy we can also test the estrogen HER2 new positivity, or with with the FNSC we cannot do that.
Okay, very good. So we did an ultrasound. Can you tell me about grading of breast cancer? On what basis is it done? Have you seen a breast cancer histopath report?
Acha, BIRADS.
No, that
Breast.
is a USC report.
Uh,
If you want to tell me about BIRADS, first tell me about BIRADS.
Sir, BIRADS is breast imaging, recording, and data system.
Okay.
Uh, six
BIRADS
by
1 is, BIRADS 6 is there. Up to 6 is there. Then what else?
six is
What is
there.
BIRADS 1, 2, 3, 4, 5, 6?
BIRADS 1 is no pathology detected. BIRADS, I don't know it exactly, sir. Like,
Okay. BIRADS 2 is benign, 3 is probably benign, 4 is
uh,
probably malignant, 5 is uh, highly suspicious of malignancy,
and
6 is
6 malignant.
6 is
Proven
malignancy on
malignant.
proven on what?
Biopsy.
Yes, histopathologically proven. The biopsy is BIRADS 6. So suppose a patient you sent to a radiologist and they gave you BIRADS 6 report. Is it okay?
No, sir, because they have not done the biopsy.
Yeah, but if you send the patient with the biopsy to the radiologist, then they can write BIRADS 6 because they have seen the report, right? But if you have not done the biopsy and you just send it to the radiologist, the maximum they can give you is BIRADS 5. Okay. What are the, and you must know the chances of chances of malignancy. It is 0.2% in BIRADS 2, Birads 3 is 2%, Birads 4 is 20%, Birads 5 is 80 to 90%, 98%, and Birads 6 is 100%. Okay, that you should know. You should also know the recommendation for each of them. What is the recommendation for Birads 1 and Birads 2?
So Birads 1 is no malignancy, so routine screening.
Okay, Birads 2?
Again, the risk of malignancy in Birads 2 is
Less, so
less,
just
so
routine screening.
routine
Birads
screening.
3?
It's short intervals will follow up
Very good,
because
very
it
good,
may
very
turn
good.
into malignancy.
Do you need a biopsy on Birads 3?
Not necessary, but with routine follow up if
Very
anything
good, very good.
suspicious.
How do you compare Birads 3 versus Thyroids 3?
Sorry, sir.
Birads 3 versus Thyroids 3. Thyroid may be same hota hai, right? There is this thing for everything. Pyrides, lyrides, birads, thyroids, everything is there. So for thyroid 3, Thyroids 3, then what will you do? In Birads 3, the recommendation is short interval follow up with imaging, right? And what about for Thyroid 3?
Biopsy.
Biopsy, if it is more than 2.5 centimeters, you have to do FNS. Okay. Thyroid 3, more than 2.5 centimeters, do FNS. What about Birads 4? Then you will have to do?
Since it's suspicious, so biopsy to be
Biopsy.
done.
What are the different types of biopsy? I'll tell you the names, you tell me the meanings. Incision, excision, punch, true cut, fine needle, whatever. What is incision biopsy?
Incision biopsy is we'll only take a certain part out of the lump.
Okay. And what is excision?
The whole lump along with negative margins will be excised out.
What is punch biopsy? Usually used for?
True cut or अपना core biopsy.
That is core biopsy. What is punch biopsy? Correct. Whoever is answering. Really is answering. Punch biopsy is used for skin conditions or fetish disease of the nipple, or usually dermatologists do punch biopsy. They have a special punch biopsy instrument where a whole punch, a vertical part of needle can be removed. A part of skin can be removed. That is punch biopsy. Okay. Where was we before that? Before we talked about Birads, we were discussing about something. No?
Grading.
About histopath report, yeah. What are the things that you see in a histopath report of a CA breast? First, it will tell you the type of the cancer, whether it's malignancy. So whether it's infiltrating ductal carcinoma or whatever. Okay. Then it will tell you the subtype. What else?
Type. The HER2 new ER positivity if done.
ER status, PR status, and HER2 status. What else? Grading will be there. Grades will also be given, right? Grade 1, grade 2, grade 3. For a true cut biopsy needle, you will get all this information. So for the grading, there is a score called Bloom-Richardson score, BR score. Based on that score, they will tell you the grading. Okay. So let's come back to breast abscess. How will you treat? So you have done the imaging, and imaging has shown a breast abscess. Since clinically you have said the size was 5 by 4 centimeters, right?
Yes, sir.
Yeah. Suppose there is a breast abscess and imaging says the size is about 3 by 2 centimeters, and all the other things are same only. How will you proceed? Score is
it's a breast abscess which is of 3 by 2 centimeters.
Yeah, if it's a small breast abscess, clinically you see there's a breast abscess which is small. Will you conserve the patient with antibiotics, or will you do any intervention?
So first we'll try conserving with antibiotics. Don't know exactly.
There are certain areas where abscess cannot be left alone because you don't know the depth of the abscess. Suppose clinically you are seeing the size. I said clinically, right? Clinically the breast abscess size was 3/2. Okay, but you will not know how deep the breast abscess is going because clinical size will not correlate with the radiological size of the breast abscess inside. So in areas of gluteal abscess, breast abscess, carotid abscess, uh, and I think one more thing was gluteal, breast, salivary, and I think psoas abscess. In all these four places, I'm not sure of the fourth one. In all these places, you will not wait for any size criteria, whether you want to do intervention or whether you want to do just antibiotics. You will always drain the abscess. Okay, are you with me?
Yes, sir. Okay, sir.
So breast abscess you have to treat. That is the first thing I want to take. I want to take home. So how will you treat the breast abscess? What are the various ways of draining the breast abscess?
Incision and drainage.
What else?
USG guided. nahi?
Yeah, USG guided aspiration
Needle
of
aspiration.
needle aspiration of breast. See, the antibioma is not the reason. The answer I told you is because you will not know how deep the abscess is, and you will not know the true volume of that. So it's always better to uh, drain the abscess. Okay. So the two possibilities that you have in mind are drainage and USG guided aspiration. What will you choose amongst the two?
So since it is clinically seen, so we can do incision and drainage directly.
Okay, fair enough. I accept your answer. Uh, Classically, people have been doing IND for breast abscess since a long time, but now the recent recommendations are that repeatedly you can do USG guided aspiration for the breast abscess, and after that, if it still fails after recurrent after many episodes, then you should proceed with the open IND. But since you already said this patient has had breast abscess previously also, and it is quite large in size, we can proceed with directly IND, and even at your undergraduate level, if you say IND, that is a good enough answer. So what kind of incision will you take for breast abscess IND?
Curvilinear.
Curvilinear, very good. Because of what reasons? For cosmetic reasons.
Uh,
Uh, what other incisions of the breast that you know of? For fibroadenoma, which incision will you take?
circumradial.
Circum,
Radial.
circumareolar.
Circumradial.
Circumareolar. Because that will give you a superior cosmetic outcome. Just at the areolar, at the junction of the areola and the breast, you will take the incision. But circumareolar incision has a negative, yeah, Gillard Thomas is another. Has a negative point, which is that can you take a circumareolar incision all over? Maximum you can take is up to the 50% of the breast. You cannot extend it more than 50%, right? Because it will cause injury to the lactiferous ducts around. So you have to be careful when you take a circumareolar incision. Suppose the breast abscess is away from the nipple, then you can directly take a curvilinear incision over there, over that part, and you can keep it open. Okay. And what about what is Gillard Thomas incision?
It is the inframammary incision.
Inframammary crease incision. Very good. Suppose the breast abscess is down there, then you can take the incision over there such that it will not be seen after that. Suppose you have a fibroadenoma or a breast abscess in the lower quadrant of the breast, lower two quadrants, right and left. Then what kind of incision that you would you like to take? Will it be
The
circular or will it be radial?
the lower.
In the lower part, you should take radial incision. In the upper part, you should take circular incision. Circular, you mean? I mean curvilinear incision. Okay.
Okay.
Last few questions now. Suppose patient has galactosile which went into causing breast abscess, because that is a very common clinical scenario that you see. You will usually see a young mother, mostly that is she'll be a first time mother because she might not know, or some people may not have counseled her properly the importance of breastfeeding and all that. So in young females who have become mother for the first time, they may not know the importance of emptying the breasts properly. So they have galactosile formation, and which can get secondarily infected to cause the breast abscess. So if a patient has breast abscess and she is breastfeeding, what advices will you take? Will you tell the patient to stop breastfeeding or not?
No, sir. Continue with the breastfeeding.
From the same side or from the other side?
Same side, both the sides.
From the same side also. See, as far as possible, you can, if there is another option, you can tell the mother to continue breastfeeding from the other side. And you can, important thing is you have to empty the breast where the breast abscess is already there. You cannot leave it as it is, because otherwise there will be tense. It will become tense and it will become reddened. Okay. At least you have to get it drained by a manual pump, and otherwise the child can still, you can still allow breastfeeding from that breast also. Okay.
Yes, sir.
Last question. What antibiotics will you start empirically?
Empirically. Doxycycline, aminoglycosides, tetracycline.
Aminoglycosides are for gram negative. Tetracyclines are broad spectrum. What kind of organisms are you suspecting which cause breast abscess?
Sir, Staphylococcus aureus is the
Yeah,
most
gram
common.
positive, right? So what kind
Yes.
of antibiotics will you start?
Sir, penicillin group of antibiotics.
Yeah, something that will cover gram positive. That will give you gram positive cover. Aminoglycosides will not give you gram positive cover, right? Vancomycin, if there is resistance to the first line antibiotics, only then you will proceed to all those higher antibiotics. Directly, you will not start. Okay. Any doubts you have, audience?
Sir, in this case, later on, the patient was on further investigation, USG and all, ductectasia was present as the underlying cause of the breast abscess. So this, in this also we'll continue with the normal. So we'll go for an excision directly, or we'll wait and then see.
If the what is the age? 40-year rule, no?
Yes.
And the breast abscess was away from the breast nipple area, no?
Yes, sir. Upper outer quadrant.
You can finish it in the same. I'm not really sure, but I think you can do it in the same sitting. Proctectomy, microdectomy. I'm not really sure. I'll get back to you. Okay. Anything else? I can ask you a questions. If you all have time, I can take you. I can take the viva towards breast cancer if you want, because that is a very common case that will come in the exam. Breast abscess is less likely because the patient will be in pain, so they will not allow the patient you all to touch her again and again. Breast cancer can be easily cured.
Yes, sir. We can.
Yeah. Method. Yeah, we can continue till 1 o'clock, 20 more minutes. So methods of breast palpation are dial o'clock method, concentric circular method, vertical and horizontal, with minimum 50% overlap with the previous palpation. Previous step. Every step should have a 50% overlap with the previous step. And you have to do it with superficial pressure and then deep pressure for finding out lumps which are present deep to the skin. At every point, you have to give superficial pressure and then deep pressure. Okay. So if you come to a lump in the breast, which is malignant, which is hard, you have done with the triple assessment. We have discussed about the importance of true cut biopsy over FNAC. And now a patient has clinically the axillary is negative, on ultrasound also axillary is negative. The size of the breast lump is 3 by 3 centimeters. What will be the stage of the tumor?
3 by 3 centimeters.
On
No
vernier caliper.
metastasis.
No metastasis.
T2.
Can you tell me the T staging?
TX is not detectable. TX it was excised. It is not present anymore. T0 is not detectable. T1 there is carcinoma in situ. TIS is
TIS.
TIS is carcinoma in situ. T1 is more than 2 centimeter. Sorry, less than 2 centimeter in the greatest dimension. Then T2 is more than 2 centimeter but less than 5 centimeter in the greatest dimension. And then T3 is more than 5 centimeter. T4 is it extends to the chest wall.
T4A. T4
and
ABCD. What is T4A?
Chest wall. T4A is chest wall, extends to the chest wall. T4
What is chest wall
B.
involved?
Sorry, sir.
Chest wall में क्या क्या आता है?
Pectoralis major.
No. Most important point. Most important point. So everyone suffers over it. Pectoralis major is not a part of T4A. Even if the chest pectoralis muscle is involved, the tumor's staging will still be T2. This is T2, right? I have said 3 centimeters. So it comes under T2. So even if the pectoralis muscle is involved or not involved, it will still be T2 only. Okay? समझा? समझने जैसा कुछ नहीं, you have to learn. Very good question. Serratus anterior will cause. That was my next question. In fact, what if serratus anterior is involved? Then what will be the stage?
Serratus anterior.
3 centimeter lump, serratus anterior is involved. Then will it be T4A or will it be T2?
Serratus anterior is chest wall, no? So I think it will be 4.
Yes.
T4A.
So the chest wall involvement consists of basically the gist is chest wall involvement includes serratus anterior, ribs and the interpectoral muscles, but not pectoralis major muscle. Got it?
Yes, sir.
What is T4B?
Ulceration over the lump.
Over the skin. T4A is under, T4B is bahar. Okay? A is under, B is bahar. Bahar is skin. So what is skin involvement? 3 ways you can see for skin involvement.
Skin fixity.
Ulcers, nodules and peau d'orange. Okay, those are skin involvement. T4B. What is T4C? A plus B. And what is T4D? Inflammatory carcinoma. Okay. What is N stage?
N0 is no regional metastasis. N1 is ipsilateral
Mobile.
Mobile.
N1 is a mobile axillary. N2?
N2 is fixed, not mobile.
N2A.
Matting of the lymph nodes.
Yeah, fixed. Then?
N3 is
N2B भी होता है ना?
अच्छा mammary nodes. We start involving the other apart from the
internal mammary node. See, N1 axillary mobile, N2 axillary fixed, N2A axillary fixed, N2B internal mammary involved. Now we come to N3. N3 is again over here. That is
clavicular, infraclavicular. Sorry.
Infraclavicular. Then N3B is 3A is infraclavicular. 3B is 2A plus 2B. That is this and this. And then N3C is
supraclavicular. It goes up.
Got it? And M0, M1 we all know. So what is early breast cancer? Clinically, when you talk about treatment for breast cancer, you have to start with 3-4 scenarios. The first scenario is in situ. Second is early breast cancer. Third is locally advanced breast cancer. And fourth is metastatic breast cancer. And fifth is breast cancer with pregnancy. These are the 5 clinical scenarios in which your management will decide. So whenever you get a breast lump case, it will not be a pregnant case for sure. It will not be carcinoma in situ, very unlikely. It will either be early breast cancer, but even higher chances of it being a locally advanced breast cancer. Metastatic breast cancer also they can give you if the patient is of a good Karnofsky performance status. All of the patient is doing well, not very moribund and all, then they can give you all these three. Okay, early breast cancer, it's unlikely that these patients come to our government hospitals because usually all the patients get diagnosed late. So locally advanced breast cancer is one of the most common patients that you get. So what are the stages that are involved in early breast cancer? It is stage 1 and stage 2A and stage 2B. Okay, only these three patients. These three groups will come in the early breast cancer, and the rest, stage 3A, stage 3B, will come in the locally advanced breast cancer. And the last one was metastatic, that will be M1. So that will be stage 4 patients. Got it?
Yes.
Stage 1 and 2A, 2B.
Mm.
Stage 3A, 3B. Stage 4, pregnant women will not come, in situ will not come. Got it?
Okay, sir.
So now let's discuss these three quickly. Early breast cancer, stage 1 or 2A or 2B. So in that, stage 1 will be T1 or T2.
Mm.
And maximum up to in this thing, in this point, early breast cancer. Let's discuss this first. In this, maximum you will get is N1. Okay?
And
T3 N1, either it will be T2 N1 or it will be T3 N0 in this. So basically, the swelling will be around less than 5 centimeters or even less than 2 centimeters. It is possible. And the maximum lymph nodes that will be involved is axillary, nothing else. That too, it will be mobile. That will be early breast cancer. So how will you treat early breast cancer?
with if it is not involving any metastasis, then we can go for just the removal lumpectomy and using chemotherapy, adjuvant therapy for conservative breast surgery.
Okay. So what surgery will you do? Lumpectomy. That is called breast conservation therapy. BCT it is called, right? BCT
Yes.
includes breast conservation surgery, that is lumpectomy, and then adjuvant chemo and adjuvant
Radiotherapy.
radiotherapy. What are the indications, contraindications for BCT? Breast conservation therapy. Very important question.
BCT.
In what patients can you do BCT? And in what patients will you not do BCT? See, early stage cancers, will you do BCT? Early
Yes,
stage
sir.
we just discussed. Yes.
Yes,
In
sir.
metastatic, will you do BCT? No.
No,
In
sir.
locally advanced, will you do BCT? No. Okay, that is the first point.
No.
Then earlier पहले बोलते थे कि when the breast size is 4 centimeters or more, you cannot do BCT. If it's less than 4 centimeters, we can do BCT. But now the new concept is there is nothing like a size criteria. It will always be determined with the relative size of the breast and the relative size of the tumor. If the breast is small size and the tumor is big, then you cannot do BCT because it is as good as removing the whole breast. ठीक है, conservation करने के लिए कुछ होना चाहिए ना. So usually, if it's less than 4 centimeters in size, you can do BCT, but the breast also has to be sufficiently large in size. Then you can do. So yeah, the perfect term is large tumor size relative to the breast size. So early stage cancers, large, small tumor and large breasts. In that you can do BCT. What else? Patient should not be pregnant. You should, if the patient has pregnancy, then you cannot give radiation. So BCT gets contraindicated. If patient has prior radiation surgery, radiation taken already, patient has mediastinal diseases where where radiotherapy becomes contraindicated, then you cannot give BCT also because radiation therapy is compulsory after BCT. Suppose patient is very poor and is coming from some village where she does not have facilities. Patient is not even educated. She does not have good family support also. So if you give BCT and if the patient goes and she does not follows up for if she does not follow up for radiation, then you should not offer BCT to such patients. Then you should offer MRM even for early stage cancers. Got it?
Yes, sir.
So BCT should only be given for patients who are early stage, large breast, small tumor. Bolo.
Uh,
No
patients
prior
can
radiation,
follow.
no contraindication for radiation, non-pregnant, consent, determined patients, educated patients who will follow up with you. Samjha?
Yes, sir.
Uh, Next is then adjuvant radiotherapy and adjuvant chemotherapy. Do you know of the chemotherapy regimens?
CMF and CAF.
Okay.
So
Which one is 3 weekly? Which one is 4 weekly?
CMF is 21 days, so 3 weekly.
4 weekly. CMF is 4 weekly.
Acha, CAF is 3 weekly.
methotrexate सबसे पुराना ड्रग है, तभी 4 वीकली होता था, but now no one does 4 weekly because it will take more time to do the to give you chemotherapy, no? So now we finish the uh, chemotherapy 3 weekly, 6 cycles are there, even for neoadjuvant or adjuvant. So what are other second line chemotherapy regimens, if you know any? Paclitaxel means?
Sorry, sir?
Paclitaxel. You said about CAF, no? That is cyclophosphamide, adriamycin, and fluorouracil, 5-FU. The newer regimens are contain paclitaxel. So adriamycin cyclophosphamide with paclitaxel is given right now. These are the better chemotherapy. Okay, these are all 3 weekly, correct? That is also an important question. Then we come to radiotherapy. Radiotherapy is how much dosage of radiotherapy has to be given? How many centigrades of radiation dose is to be given?
Don't know, sir.
4,000 to 5,000 centigrades. It has to be given in divided doses. Radiation is goes on from like 5 days a week. Monday to Friday they are called. They give radiation. At one time you can give radiation of up to 150 to 200 centigrades of radiation can be given in one sitting. So total, if you want to give 4,000 to 5,000 radiations, it will take you 25 to 30 days. Okay. And if you take Saturday, Sunday ka holiday, it will take 30 to 35 days to complete your radiation therapy completely. Okay, 5 days a week for 5 to 6 weeks. That's correct. Tanishka. So per day is to about 200 centigrades, and total radiation dose is 4,500 to 5,000. What is the dosage of 1 mammogram? How much radiation is exposed in 1 mammogram?
100 rats.
100 rats.
Sorry, sir. I don't remember.
0.1 centigrade.
0.1?
Yeah, centigrades.
Centigrades.
How much is 1 radiotherapy dose? I said 180 to 200 centigrades. And 1 mammogram is 0.1 centigrades. Centigrade, GRAY, centigrade. And 100 centigrades will give you 1 gray. That is the common thing. X-ray ka bhi dose is very important. No, it's 0.1. Then radiation therapy. What about hormonal therapy? If the patient is ERPR positive, then you will offer hormonal therapy to the patient after surgery. Okay. What is the dose? Which drugs will you prefer? For a premenopausal woman, which drug is given as hormonal therapy? Tablet, tamoxifen. Dose?
200 milligram.
20 milligram. 20 milligram per day. OD is given for how many years?
5 years.
5 years earlier. But recently now they have extended it to 10 years. Textbook mein 5 years hai abhi, but now they are giving it for 10 years. And we are also giving it for 10 years now. 20 milligram per day for 10 years. What is the class of drug? Tamoxifen is a
estrogen receptor.
Selective estrogen receptor modulator. What drugs will you give for postmenopausal women?
The aromatase inhibitors.
Why?
So because that will prevent the conversion of the peripheral conversion of peripheral production of estrogen from the adipocytes and the adrenal glands.
But tamoxifen क्यों नहीं देना? Why do you want to have a new drug? Is there a problem with tamoxifen? Raloxifene is better than tamoxifen in side effect profiles. So you want to give tamoxifen or raloxifene, it depends on the patient's purchasing power. But for all the premenopausal women, you have to give tamoxifen or raloxifene. Both are okay. So yeah, for coming back to the question, for postmenopausal women, which drug you want to give? You said you want to give aromatase inhibitors like anastrozole, right? But why? If I say I want to take tamoxifen, then is it okay?
Tamoxifen, because of the estrogen modulators, it it may cause DVTs. The side effect is DVT in tamoxifen. So already in premenopausal age group, they are postmenopausal age group, they're already at a higher risk of thrombosis and hot flashes. So
Okay.
all those.
Basically, you mean to say that tamoxifen has a lot of side effects. That is why you don't want to give it in postmenopausal women, right?
Yes, sir.
Okay. But then, how is it that why don't you give letrozole, anastrozole in premenopausal women also? तो tamoxifen उनको क्यों देना है? उनको भी aromatase inhibitor दे देते
Mm. Because there is a reduction in peripheral conversion of estrogen in the aromatase inhibitors.
हैं.
Decreased levels of estrogen may lead to osteoporosis wala logic mein?
नहीं.
Don't know, sir.
The answer is in front of you ना. Menopausal and premenopausal में difference क्या है?
Levels of estrogen.
Secreted by whom?
Oh,
Ovary
the
is functioning in.
हाँ.
Ovary is functioning in the premenopausal. It is non-functional in the postmenopausal. Okay.
Mm.
So even if I give aromatase inhibitors in the premenopausal woman, ovary तो अभी भी है ना. I'm not stopping the ovary. I'm stopping the peripheral conversion of estrogen. What is the source of estrogen in premenopausal woman? It is ovary. So to block that, you have to give tamoxifen or raloxifene. But in the postmenopausal woman, ovary is not there. So the only estrogen that is left, थोड़ा बहुत जो है, वो peripheral convert होके मिलता है. That you can stop by AIs. So you don't need tamoxifen का side effects, and you don't need to give tamoxifen for postmenopausal women. Okay? So hormonal therapy. What other indications? If there is metastasis, can you give hormonal therapy? Will it be beneficial in a metastatic breast cancer? It will be beneficial if there is bone metastasis. Then it is very helpful. Okay. That brings to the question: what is the most common site of metastasis from CA breast percentage wise? Top 3, top 4 sites.
Lungs.
First is bones.
First is bones.
Bone, lung, liver, vein. Okay. 40% of the metastasis is to bones first. What scan will you do for suppose you want to look for metastasis? The patient has locally advanced. No, well, let's go stepwise. BCT samjha for early stage cancer.
Yes, sir.
You do a surgery, breast conservation surgery. I told you the contraindication indications. Then the adjuvant chemo, adjuvant radio, and hormonal therapy based on the receptor status. And if patient is HER2 positive, then what will you give?
Trastuzumab.
Okay. What is the cost of trastuzumab?
Don't know, sir.
Range. How cheap is it?
20,000 to 30,000.
Yeah, basically you have that idea. It's very expensive. All the monoclonal antibodies are expensive. Okay. Around one vial will be having about 400 milligram or something. It will cost you about 50 to 60,000. And your intake of thing will be depending on your weight. So you have to take about 12 cycles of trastuzumab. 12 monthly. It takes 1 year. You have to consider that. And it's very expensive. So that is, we talked about early cancer. Now we come to locally advanced. What will you do for locally advanced cancers?
The triple assessment and the PET scan to detect the metastasis.
Okay. Which scan is better for bone metastasis?
Sulfur colloid.
Technetium 99 bone scan. Then that is locally advanced. So in locally advanced, what will you do? Suppose metastasis is not there. This is this one. I'm talking about LABC, but M0. Stage 3A, 3B. What will you do?
MRM.
But before that, would you like to give something else?
Chemotherapy to decrease the size of the lump.
What chemotherapy is called? Neoadjuvant chemotherapy. Again, 6 cycles you complete. The same chemotherapy which you are giving year post surgery, you give it all the 6 cycles, you give it pre-chemotherapy. Okay. And then same thing after chemotherapy, you have to give minimum of 3 to 4 weeks of interval after completion of chemotherapy, and then you post the patient for surgery. What surgery will you do? Quickly, it's 1 o'clock.
MRM, modified
MRM,
radical mastectomy.
radical mastectomy. Can you define modified radical mastectomy?
It is the removal of the whole tissue of the breast along with the associated lymph nodes in the axilla.
What is the from what level to what level? From the clavicle top, sternum midline on the medial side, laterally up to the anterior axillary line up to the axilla, and inferiorly up to the sixth rib. All these things you have to remove. Removal of the whole breast along with its nipple areolar complex, with the borders that I have just told you, along with the axillary tail of spines, along with the axillary level 1 and level 2 of lymph. Okay. Usually level 3 lymph nodes are not removed commonly. Only level 1 and level 2 are removed. What are the 3 types of MRM? Patties. Have you heard of this?
Yes, sir, I've heard, but I've forgotten the exact
Forgot. I'll tell you the mnemonic. PSA. Patty. S से कौन है? Scanlon. A से Ocean clause. PSA. Prostate specific antigen होता है ना? Same. PSA. Patties. Scanlon. Ocean clause. ठीक है? And everything will become better and better. Patties ने क्या किया था? Pectoralis minor को. What are the difference between the three?
Patties is en bloc dissection, वो पूरा निकाल दिया.
MRM is the same in all these three. First was radical mastectomy, which was done by Halsted. I will come to that later. Then came Patties. पर Patties ने pectoralis minor के साथ क्या किया? He cut the pectoralis minor. सबसे बुरा था. Then comes the better one, which was Scanlon. What did he do?
Don't know, sir.
The Patties cut it. Scanlon divided it. And what did Ocean clause do? The best person? He just he retracted it, conserved it by retracting it. Okay. So what MRM we do usually nowadays? Out of these three, which one we do?
The retracted, the Ocean clause one.
Ocean clause one, correct? So what is the mnemonic? PSA. Okay. Then yeah. So only level 1 and level 2 lymph nodes are usually removed. Level 3 usually are not removed because there is a risk of injury to the axillary vein, and usually level 3 lymph nodes are not always involved. Okay. Level 3 is we saw na N3C में आता है. Supraclavicular lymph nodes, infraclavicular lymph nodes and all. It's usually not involved. So only level 1 and level 2. How many minimum lymph nodes should be removed in the histopath report when you are checking for MRM? After MRM, you send the specimen for histopath and you see how many lymph nodes they have found. Minimum कितना आना चाहिए?
3 to 4.
Minimum 10 to 12 should be there. Okay. What things will you see after MRM has been done? Patient specimen has been sent. You got the histopath report. What will you see in that? You will look for lymphovascular invasion and you will look for any extracapsular extension. You will look for positive margins and all. Okay. Okay. When specimen is being sent, how will you orient the specimen? Have you seen surgeries MRM being done?
Yes, sir.
So do they tie something on the MRM specimen to tell the pathologist के कहाँ क्या था? No?
I remember the tie, but like the orientation.
What do they do, Madhur? Yeah, they attach small sutures and big sutures. Now it's no compulsion, it's no rule. Okay, long, whatever, short, superior, long, lateral. This is a convention that is followed. It is not a rule. It can be anything that the surgeon wishes. That's the thing that you have to write that same thing in the pathology form that you have to send. When you're sending the form, you should tell the pathologist that this is superior, this is inferior. So what the most usual thing that is followed is you will tie an ethylon or any other suture. You will cut it short. Suture जो रखते हैं, the thread has to be cut short, and you tie it at the superior part, and the lateral border of the specimen, the lateral border, you keep a long thread and you cut it, and then you will write short thread is in the superior, long thread is in the lateral part. But if you want, you can have nylon and silk also. You can say nylon is threaded to the lateral border. You can say silk is threaded to the medial border. You can do anything, and you just have to write it. And the main thing is you have to orient the pathologist. कौन सी चीज किधर है? What is the importance of this? And then one more thing, you have to take methylene blue and you have to put methylene blue on the lower aspect. You have to paint the base of the tumor with methylene blue. Okay, when you send it for the pathologist. Now, what is the importance of all these things? Painting, suturing.
Margins, to locate the margins of the tumor.
So the pathologist will tell you the superior margin is 0.5 centimeters away, the inferior margin is 0.1 mm away, the lateral margin is positive, the medial margin is 5 centimeters away. So you will have to come and redo the surgery. Okay, that is why the margins and the orientation is very important. What are the ways of finding sentinel lymph nodes? Two methods. What time is it?
USG and biopsy.
No, intraop.
Frozen sections?
No, to find the sentinel lymph nodes. To find, I don't know what is sentinel lymph node. It is a place where
the sulfur colloid wala dye and I think again technetium, but the
radioactive tracers and isosulfan blue dye. Blue dye is inserted at the tumor base, and you have to wait for 20-30 minutes. You have to give some massage, and when you incise over here, you will see a blue lymph node, which that color will be taken up over there. If you do the radioisotope uptake method, you will have to put radioisotope one night prior in the nipple complex and around the tumor. In the just before the surgery also you will put it. Then you will have a gamma probe, which will count the how much radiation is emitted, and you have to follow it up. And wherever the maximum radiation is coming from, that is the sign of your sentinel lymph nodes. Usually 2-3 sentinel lymph nodes are there. And what is the importance of sentinel lymph node?
Metastasis, whether mets.
No. When did the concept of sentinel lymph node come? सबसे पहले क्या करते थे? Even for early cancer, हम लोग breast cancer therapy came right now, no, in the last few years. If you go 40 years back, even if there was a 2 centimeter tumor or 3 centimeter tumor, what was the only surgery that was possible 2 years back? Many years back.
The
only MRM was there, right?
Okay.
Only MRM was there. So there was whole axillary lymph node dissection and there was whole mastectomy. Now what we do only lumpectomy and we do axillary lymph node dissection, or we do only lumpectomy and we do sentinel lymph node biopsy. Okay. So why does this concept of sentinel lymph node biopsy has come? Logic.
To preserve the breast, to preserve the axillary lymph nodes, to prevent that lymphedema.
Yeah, very good. So studies were done, and some people found what did they do? They took patients of stage 1 and stage 2 cancers. Suppose I took 100-200 patients of stage 1, stage 2 cancer, and then half of the patients I will say, okay, do routine MRM, and other half I say, no, we will only do lumpectomy and we will only take one sentinel lymph node and we will send it and we will remove that. And then when they saw the mortality and the survival, it was similar. In the early stage, you don't need to do MRM and unnecessarily give the patient morbidity, lymphedema and all that. You don't need all that. Just BCS with sentinel lymph node biopsy is enough. And even when you do sentinel lymph node biopsy, they saw not everyone was giving a positive sentinel lymph node. Okay. Then they did more studies. Then they saw, for the patients who are getting positive sentinel lymph nodes, if we go ahead and only those patients who are positive, only they will get axillary lymph node dissection. The survival is equal with those who do MRM completely. Okay. And that is how the protocol was developed. Got it?
Yes, sir.
So what is the benefit of sentinel lymph node? As someone has rightly mentioned, sentinel lymph node is negative. Now you have done lumpectomy and you have removed one sentinel lymph node. Okay. And you have sent it for histopath. Now if it's negative, you leave the patient as it is. The treatment is over. Now you only need to give a chemotherapy if it's needed and radiotherapy is needed. Okay?
Yes, sir.
Okay. And finally, stage the fourth type, which is with metastasis, patients with metastasis. What is the aim of treatment over there?
Palliative care.
Palliative. And all the surgeries, if you want to give, what palliative surgery can you do? For a patient with funkating, foul-smelling mass of breast cancer, what palliative surgery can you do?
Excision of the breast mass.
That's also called toilet mastectomy. Okay?
Toilet
You
mass.
just remove it. You don't need to look for the margins. You don't need to look for the axillary lymph node dissection. Patient is very frail, old, metastatic cancer. So what will you do? You will just remove the breast as if you are doing debridement or something. You don't need to look for margins. Patient has already metastasized. So just give her better quality of life. That is your aim. Okay. I think we should stop over there. Let's take some questions if you have any. Oh, you have a few slides left. Can you show? You want to show that?
Yes, sir. It is the investigation of the patient that was done.
That's so next slide. Ill-defined area of altered echogenicity with hypoechogenic. Okay, so these lymph nodes, what kind of lymph nodes will we see in this? These lymph nodes are called?
Rotors.
No. Axillary. Rotors lymph nodes are between the pectoral major and minor vessels. These lymph nodes in this USG finding, you can see few sub-centimeter axillary lymph nodes in the right axilla. They are called reactive lymph nodes. They are not metastatic lymph nodes. How will you determine on ultrasound whether the lymph nodes are reactive or metastatic? You will see for what word will you see look for?
Mobile. No, sir. Mobile or
No. You will look for necrotic lymph nodes.
Achha.
And others, there are other criteria for lymph nodes which are metastatic: taller than wider, rounded, loss of hypervascularity, loss of hilum, loss of fatty hilum. All these features are seen suggestive of metastatic or malignant changes of the lymph node. The discharge was clear, watery, and mastitis with that. Next slide. MRI mammogram. Okay. You didn't take any clinical photo of the patient?
No, sir. By the time we actually examined her, she was operated.
Okay. Next, anything else is left?
Only true cut was associated with and non-microbiological examinations.
See, you
CONS.
got coagulation, you get staph on you.
Yes, sir.
Okay, next.
She was given IV antibiotics for 2 weeks and she underwent lumpectomy later on. And on histopathological examination, ductectasia with atypical ductal hyperplasia with breast was found.
Okay. What is the relative risk of patient with atypical ductal hyperplasia to get breast cancer?
2 to 3%.
How many times? X? 2 to 3 times.
2 to 3 times.
For patient with BCIS and LCIS, the risk is 5 to 7 times. For patient with atypical ductal hyperplasia, the risk is 2 to 3 times. What is the incidence? What is the risk of having breast cancer in the opposite breast for a person who has already had the risk of breast cancer on one side? How many times is she more likely to get another breast cancer? 3 to 4 times. Okay. If one person has got breast cancer here, she has 3 to 4 times more chances of getting breast cancer on the other side.
Okay, sir.
Next slide.
Done.
Any other questions?
No, sir. Not from my side.
And then in the audience, in the chat box. Yeah, good case, well presented. Only I would have appreciated if you had a photo also. But you have prepared well. Thank you, everyone. Udit, we can end it now.
Thank you so much, Dr. Parth and Dr. Ujjaini. It was a very nice presentation. If there are no more questions, we can end this.
Yeah. Thank you, everyone.
Thank you, sir, for your guidance. This will really be helpful for me in the exams.